so much, ma'am. So I will be talking about day 3 versus day 5 embryo transfer. So embryo transfer we know is a critical step, and we have direct comparison between two stages of embryo transfer. Generally, they are supporting blastocyst stage transfer. And why did this happen? Because we now got this sequential culture medium, we got single stage culture medium, we have better lab culture, lab conditions, and successful culture. And we think that physiologically we will have better synchronization between the embryo and the endometrium, so we will have a higher chance of implantation. And we also believe that this is nature's way of selecting the embryo that has managed to activate its embryonic genome, so we get better live birth rate. And in PGT you don't have a choice, you have to go for day 5, and of course this will encourage single embryo transfer. But what is the opposing debate which favors day 3? So what happens is that the synchrony is believed to be similar, because when you have supraphysiological levels of estrogen and progesterone, the endometrial milieu which you get on day 3 in stimulated cycle can be similar to endometrial milieu on day 5 because of the effect of ovarian stimulation. And seriously speaking, I mean, the selection of best embryo is not actually stage based, because even chromosomally abnormal embryos can become blastocysts. This minimizes embryo wastage and it reduces the chance of cycle cancellation, increases the number of embryos for preservation. And how are we going to decide cleavage versus blastocyst? So we want the best embryo, maximum implantation, live birth rate with no cancellation, with maximum feto-maternal safety, cost, and minimum time to pregnancy. So Cochrane has published just recently, 2022, that women who are undergoing fresh blastocyst transfers, they have higher clinical pregnancy rate, which is moderate evidence, and live birth is low quality evidence as compared to those who have cleavage stage. 31% of women have live birth after fresh transfer, and 32 to 42% after blastocyst. So as ma'am was just saying that she has seen the data and the pregnancy rate is only 30%. Means with blast maximum they are quoting as 42%. The results are not conclusive, however, for frozen embryos. These were for fresh embryos. Now, when you have embryo freezing rate and failure to transfer any embryos, what is the exact percentage that this happens? So a reduced embryo freezing rate, increased failure to transfer any embryo in day 2 to day 3, it is 3.6%. In day 5, it is 8.5%. What about cumulative pregnancy rate? So there is no difference between the cumulative pregnancy rate between cleavage stage and blastocyst stage transfer here, 48 to 52%. Cumulative rate is affected not only by the success of fresh transfer but also by vitrification, because you are going to have cumulation. And single blast transfer compared to multiple cleavage transfer reduces the wastage. So that is one, single blast is probably the best advantage you're getting. Otherwise, cumulative pregnancy rates, if you see, they're almost similar. So there was 2023 in this annual meeting of ESHRE just now, day 3 or day 5 study, multi-center RCT, 1200 women. This was Dutch paper. And what they have shown was that there was no difference between day 3 and day 5 embryo transfer in cumulative live birth rate, but only if you consider the age group, that is age of 36 and over, then they were in favor of day 5 embryo transfer, because the cumulative live birth rate for 36 and under was 62% for day 3, 67 for day 5, but for more than 36 years, it is 10% almost difference. So their conclusion was that in cleavage stage and blastocyst stage, live births are almost equally likely if your patient is 36 or under versus if the patient is 37 or more than 37. So transferring cleavage stage embryos and freezing the remainder for later gives the couple more opportunity, but this does not mean that there is an increase in cumulative pregnancy rate. In fact, these additional transfers, as we know, it is a burden for the patient by increasing the cost and the time to pregnancy. So all the studies and meta-analysis which focus mainly on IVF success outcome in terms of live birth and clinical pregnancy rates was going on. But then there was a shift in focus that let us see what about feto-maternal outcome, because we have all seen, I mean, yesterday we had such a disaster. Patient who 23 weeks, she had a miscarriage, preterm delivery, then went into adult respiratory distress syndrome, had to be put on ventilator. I mean, we are just running around from yesterday. So we have to think about feto-maternal safety also. And early studies suggested that there was an adverse perinatal outcome with blastocyst transfer as compared to cleavage transfer. But there was conflicting data. I mean, there was no definitive data for this. So obstetric and perinatal outcomes after blast, this was the systematic review and meta-analysis. This another study from human reproduction, 4,600 singletons with 884 twins after this fresh blastocyst transfer. So this was the Conatus study. This is the Nordic study. And what they have shown is that day 5 means higher risk of preterm and very preterm birth with placenta previa, monozygotic twins, large for gestational age offspring, congenital anomalies, and altered sex ratio. So there was male to female ratio of 1.29 in this study. In day 3, you have multiple pregnancy and increased chance of biochemical pregnancy and miscarriage. So what was the reason that they said extended culture? Maybe there are some epigenetic changes, because the environment in which the embryo is growing is an artificial laboratory environment, not the uterine environment. So maybe there is some abnormal placentation, increased risk of preterm delivery, alteration in zona pellucida by extended culture, because of which monozygotic twinning is increasing. Male embryos develop faster, and embryologists tend to select preferentially more developmentally advanced blastocysts for transfer. Now, what is the drawback of these studies? They looked at older data. Blastocyst culture was relatively newer as compared to day 2 or day 3, only from years after the millennium, and during initial years it was just starting phase. So we did not exactly know about the media, the gas, the embryo handling. In different clinics it is different, and older blastocyst culture of course does not have the same outcome as we are getting now. So they may have some effect on these data that we have. Now, what are the perinatal outcomes of blast versus cleavage? This is published by Barkodi, Maheshwari, Bhattacharya. These are all very, very well-known clinicians from the UK, and this is a huge national data analysis. 1,27,600 singleton births, 54,000 after blast, 72,000 cleavage stage transfer. And what they have shown is that the chance to deliver healthy singleton is similar in both the groups, and the chance of low birth weight was similar. Very low birth weight, high birth weight, very high birth weight was preterm, very similar. Congenital anomalies only, they have some difference, but according to them all the percentage points was almost similar. Now, if you see congenital anomaly, perinatal versus blastocyst versus cleavage stage in single transfer, this was a systematic review and meta-analysis. Little to no difference. Slightly increased probability of male neonate after blastocyst transfer. So now after this feto-maternal, the next question comes. This is the most difficult question, because if you have few embryos, you know, nowadays patients have low AMH, we have few embryos. So what to do in this case? There is conflicting data. Some authors say that in vitro survival does not relate to in vivo. मैं कुछ नहीं कर सकती, मेरा presentation होगा 10 मिनट में फिर आऊंगी. Sorry, the anesthetist is transferring the embryos at the blastocyst stage can lead to a loss of viable embryos as a result of them not surviving the prolonged culture. And Zhao has confirmed this hypothesis in women with only one embryo in day 3, where the pregnancy rate was higher when the embryo was transferred on day 3 versus day 5 or day 6. 3 retrospective studies have also demonstrated that extended culture does not alter the implantation potential when fewer than 3 embryos are available. So overall, we see that blast transfer is non-inferior to cleavage stage transfer when patients have fewer zygotes, less than 5. And in fact, in some cases, it may even be preferable. So analysis for clinical pregnancy has not shown any difference between the blast and cleavage stage transfer in less than or equal to 5. Now, if you have only one embryo or two at cleavage stage, what to do at that time? In this case, the clinical pregnancy rate per retrieval and ongoing pregnancy is comparable between the two groups. So what they concluded was that cumulative pregnancy rate is similar for patient with 1 to 2 cleavage stage embryos, regardless of whether it is transferred on day 3 or transferred on day 5, because bottom line for us is the pregnancy rates, and there is no difference in cumulative live birth between cleavage versus blastocyst, again in fewer than 4 zygotes. This was again a retrospective study, but I put it because it is 2022, more recent study. Now, the PRECISE trial is ongoing, where we compare blast to cleavage stage transfer in poorer prognosis patients where you have less than 5 2pn, that is embryos on your day 1. So the PRECISE, which is the poor embryo yield cleavage stage versus blastostage embryo transfer trial, is that the blastocyst ET is not inferior to cleavage stage when you compare to live birth rate. And if you adapt a routine blast culture for all patients, it results in higher rate of single embryo transfer and reduced incidence of multiple pregnancy and simplified laboratory protocols. So understand this, you can do day 3. This study is not saying that you don't do day 3. It is just telling you that day 5 is not inferior. So you can do day 3 if you are doing here, but more if you are concerned more for single embryo transfer, then of course it is day 5. But here anyway you have 1 or 2 embryos, so that is not so much of a concern. So cleavage stage, basically we are never going to let it go. NICE is recommending cleavage stage transfer to avoid cancellation. ASRM also avoiding it because cancellation of embryo transfer is avoided and ultimately success rates are equal. It is a good option definitely for younger patient. Not having any embryos can be absolutely devastating. At least the couple feels they've tried everything. So till date, we don't have a clear answer whether these patients will benefit from cleavage or blastocyst transfer. In the committee opinion, which is produced by the SART, that says that in good prognosis patient, if you do blast, it increases the live birth rate and compared with equal number of cleavage stage embryos, and there is a higher implantation rate. So they are recommending ESET, which is the elective single embryo transfer. Extended culture will give you fewer surplus embryo for cryopreservation. The reliable criteria to identify that embryo which is destined to develop into a healthy child, that remains to be established. And we do know that blast culture is associated with monozygotic twinning and sex imbalance. Repeatedly in studies this has been shown. Embryologist has to have the appropriate equipment, protocol, and your lab has to be suited. So the debate is still on. Can we have the best of both? We should try and improve, standardize our blastocyst culture, evaluate new technology, use AI if we can, and see if that will help us to give us the best embryo on day 3, so we can reduce the perinatal risks and reduce the number of embryos transferred. And we need more follow-up studies on long-term health outcome of children who are born both at cleavage and blastocyst stage for a final recommendation. So our conclusion for today is that evidence supports blast transfer for good prognosis patients. Elective single embryo transfer should be routinely used to minimize the high risk of multiple in good prognosis. Future studies are required for selection of embryos. Till that time, you need to have a flexible and individualized approach. It depends on your individual lab performance and recent data. You must also keep in mind obstetric and perinatal risk. So thank you everybody for a very, very patient hearing.
Thank you, ma'am, for this wonderful talk. It's really nice to know that day 3 is not totally gone. We should continue doing day 3 and not just shift totally to day 5 transfers. Sharda Jan ma'am, please share your comments.
See, the question is, मेरे दिमाग में बैठ गया था कि जब हम FET करते हैं तो 10% सक्सेस रेट ज्यादा है, तो ऑल सेड एंड डन जब आपकी अपॉर्चुनिटी होगी तो आप ब्लास्टोसिस्ट ही ट्रांसफर करो, क्योंकि स्पीक्स गुड क्वालिटी एम्ब्रियो होगा, तो सक्सेस रेट मेरे दिमाग में भी लगता है कि ज्यादा ही होगा. बट यस, लुकिंग एट द ऑब्स्टेटिकल एंड पेरिनेटल प्रॉब्लम्स, आई थिंक cleavage is not to be dumped. Day 3 transfer stands. It is no inferior than day 5 transfer. I put it the other way.
Correct. So it is not inferior. You can
सर आप
go
क्या
for
कहेंगे?
day
आप
5.
ब्लास्टोसिस्ट प्रेफर करोगे कि डे 3 प्रेफर करोगे? और शिवानी आप भी अपनी प्रैक्टिस बता के जाओ.
मैम आई एम यूजिंग बोथ. मैं तो डे 3 भी बहुत करती हूँ एम्ब्रियो ट्रांसफर, बिकॉज आई डोंट डू सिंगल ट्रांसफर. आई ट्रांसफर प्रेफरेबली 2 or 3 एम्ब्रियोज. सर आप बताइए.
Actually, it all depends how many embryos we have got. So if we have less number of embryos, and then I think it's better to transfer them early, that is day 3, rather than waiting, and have no transfer, because our patients will never appreciate that. In NHS, it is possible to say patients, okay, we are cancelling. In India, it may not be possible. So if the number of embryos are less, definitely I would like to do the day 3 transfer. And secondly, in case the previous blastocyst failure has happened, then next time if I have to do it, next time I will, if I have got frozen day 3 embryos, I will transfer day 3.
Correct.
Yeah, because the uterus has got. I always tell my patients, the uterus is not a dumb organ. It is a very, very intelligent organ. It can detect even small problems in the embryo, and it can repair them also. So the which opportunity we lose it when we put blastocyst. So when the 8-cell embryo is there, that also had that abnormality, and the blastocyst also had abnormality. But the blastocyst lost that opportunity because it was cultured outside. So now I put the day 3, then I find that next time she becomes pregnant. So it all depends upon the patient, the variables like number of embryos, previous history of failure, whether it was a blastocyst earlier or a day 3 embryo transfer earlier which had failed. And also sometimes rarely, when I find there is no reason for the patient to have a failure implantation, I do the sequential transfer also. So I would transfer, say, maybe 2 day 3 embryos and 1 day 5 embryos, and I get a pregnancy with that, because final aim is to get the pregnancy. So a patient,
डॉक्टर पाई तो सीक्वेंशियल ट्रांसफर को बहुत प्रमोट करते हैं.
yeah, no, it is fine, madam. That also depends upon the number of embryos which you have it.
Okay.
So that is a issue. So, but as a primary, I would not use it as a sequential embryo transfer the first, because it has got some disadvantages also. Because you are disturbing the endometrium 2 times during the embryo transfer, and also maybe you are introducing the infection. Whatever we may say, cervix would never be sterile, and your catheter is passing through that only. So you are introducing the infection twice in the uterine cavity. But yes, there is a subgroup of patients only where I would prefer to do sequential, but not as a overall picture that everyone I will do the sequential transfer.
What are those subgroups in which you'll prefer sequential transfer?
Yeah, where earlier she comes with the history of somebody has done blastocyst transfer, she did not implant. Somebody had done the day 3 transfer, she had not implanted. Now what extra I can do it? So, and I have thoroughly investigated. I don't find any reason for failure, of the implantation. I've excluded tuberculosis, I've excluded infections, everything. And then under those circumstances, or in my center also, the patient has undergone one day 3 transfer and one blastocyst transfer, or 2 blastocyst transfers, and she has failed. So under those circumstances, I do the sequential transfer, that is day 3 as well as blastocyst. So day 3, I put 2 embryos, and blastocyst, I put 1.
Okay, sir.
Like today, only one patient, she had multiple small fibroids, and one didn't know what was the reason why she's not implanting. And this was a 3rd transfer for her. And this time I did this sequential transfer, and touch wood, she is pregnant today.
Oh.
So there is a subset of patients, where
सब आईवीएफ में तो
you
मेरे
can
को
try
एक
this.
चीज लगती है कि इसका कुछ कह ही नहीं सकते. You can't speak anything which is going to succeed and which is not going to succeed.
Yeah, I think, madam, sometimes you get the premonitions that I should do this to her. I do not know that, and that thing works. And many times, or if you go by the book, it doesn't work. So there is something more. I always say that IVF is not a pure science. The God's intervention is very, very important in this. And somehow, you get that idea, let me do this. Or that you are going to do the transfer, no, let me wait for 2 hours. It come to your mind. You just go and see the embryo before the transfer. Because I do it personally, I always see the embryos in the morning. And then I tell my embryologist, okay, at this time I'll do the transfer. I do not know why the time comes into my mind. Otherwise, all of them are expanded and blastocyst. So I said, no, this one I'll do later. I'll do this earlier, sequentially. So I think there is something more to IRT than basic sciences, what we all know it. I'll tell
Occult
you,
sciences
Wants
is
to
बहुत
share
give an
anything?
example. I'll just give one example, madam. One lady, she had I think I mentioned about this case anyway, just to repeat it. She had a very thick adhesion in the uterine cavity for which a histoscopy was done and it was open and the cavity was all right. And on the day of, she was having very low AMH, only two oocytes and only two embryos, day 3, grade 2 embryos. No, day 2 embryos. Out of that, instead of 4 blastomeres, there were only 3 blastomeres. One was already fragmented. Now, the thing was, she wanted with her own egg only, and I could not freeze that embryo. And I tried to do the transfer. So, at the same place where they had done the additional my catheter got stuck. So, I knew that possibly the lesion has formed again. So I sent the embryos back to the inner sounding, firstly with the outer catheter, softer catheter, then it wouldn't work. Then I used the sound, and at sound got stuck at the same place. So I could not freeze those embryos, they were anyway grade 2, and I could not transfer because there was no place I could go. So I just gave a little jerk and that passage opened up. And then I did the embryo transfer. And I told the patient, look, I put the embryos, I don't think it will work. But anyway, take these medicines. I gave her minimal support also. And she was blessed with a daughter, also a healthy child. Well, everything was against her to become pregnant. Everything was against. Because that injury might have caused a little bleeding also in the uterine cavity. Because I had done the sounding to break that adhesion. And still grade 2 embryos on day 2. But it had to happen, it had to happen. So
डॉक्टर
we
साहब
should
somehow
never say
मेरा
no
भी
to the patient.
मेरा भी
We never
एक्सपीरियंस
know.
है जब बहुत डिफिकल्ट ट्रांसफर होता है ना वो पेशेंट तो जरूरी प्रेग्नेंट होगी.
I know.
सर आप usually day 3 करते हैं day 5 करते हैं if it is
No,
given a
I
choice?
do. If I have got a good number of embryos, I do day 5. If I have, say 3 or 4 embryos, then I do the day 3 transfer with 2 embryos, and 2 I would freeze it for future use. But 4 embryos, I would not go for blastocyst. 6 होगा तो blastocyst.
एग्री 6 होंगे तो ही ब्लास्टोसिस्ट पे ले जाएंगे.
So
3
that
4 पे
I have
ब्लास्टोसिस्ट ले जाने हाँ
2 to transfer and maybe see normally statistics 70% of eggs should fertilize, and out of that fertilized embryos at least 50% should become blastocyst. If that is happening in your lab, that means your quality control is okay. So if I have 6 day 3 embryos, I know that at least I will have 3 blastocysts or maybe 4. 6 भी हो सकता है, but at least statistically I'll have 3 to 4 embryos. So 2 I'll be able to transfer and 2 or 1 or 2 I'll freeze it. But in case I have got 4 only eggs, that is the possibility that I may have 2 embryos, I may have 1 embryo blastocyst or maybe none. So then there will be a problem.
anybody wants to share anything?
Dr.
Please.
Seema ma'am.
Yes, all experts.
Dr. Seema ma'am and Dr. Megha. I don't think they
Nick also is here. Anybody can wish to share anything.
Nothing more to add, ma'am. Sir has said enough. But yes, in a smaller lab like us, we don't care to go every time for blastocyst until unless we have a good number of embryos. So this is the truth, and I accept that. And we get a good result of day 3 transfers, no problem.
Gold is gold, ma'am, basically.
Because uterus has got a, some capacity to repair the embryos, even if there is a small problem is there.
Sharma sir, I just got this thing that we have to pray up to that level that we should get that intuition as you get. So we should
No,
be
no.
all.
With the time, it comes. Okay.
It comes.
Because on that day, the way the patient was jumping and everything, but I said, no, I have to put this embryo because I can't freeze it grade 2 embryo, day 2. What's the point freezing it? And I didn't want to throw the embryos and cancel this thing only. Everything was
Yes,
against.
then I really close my eyes and I just pray and I think what to do. And whatever comes in my mind, I do that.
I know.
Please, that thing, dale. Matlab, it is so difficult sometimes, and I just pray and then.
Yeah, I think
Cancellation nobody likes. They can't pardon you.
Okay,
They
thank
can't
you very
pardon
much, everyone.
Thank you so much. Thank you so much. Thank you so much.
Sir, I wanted to ask you something. आप अभी non-invasive PGT कर रहे हैं क्या sir?
Actually, I have not taken the permission as yet from the PCP NDT. Because for that also you require to apply for it. And
Right.
I have not taken the permission as yet because, I had to, I thought let my registration come first. Then I will take the permission. And I do not know how much it will be effective. I don't know. But still, at least it is less invasive than the normal PGT.
Yes, sir.
So I think the surety test, what they call it. So, but I have not started as yet.
Okay, sir. Thank you, sir. Thank you so much.
Thank you so much, sir. Thank you
Thank you.
for being a part. Thank you so much. Namaskar, ma'am. Thank you so much.
Thank you.
Thank you, Dr. Shweta. Thank you. Bye-bye.